Hey, everybody. Welcome back to another episode of Confessions of a Male Gynecologist. I'm Dr. Shawn Tassone, America's Holistic Gynecologist. And I wrote a book a while ago called The Hormone Balance Bible through HarperCollins. It's the 12 most common hormone imbalances in women and break it down into archetypal language, which makes each of these easier to understand and also gives you a 6-step process on how to fix these issues naturally, with only one of the 6 steps being hormones. The others you can deal with on your own, like exercise, nutrition, supplements, a spiritual practice, and even energetic aspects of medicine. So check that out. You can get it on Amazon. It's about $16 to $18, depending on the pricing at Amazon. And I think it's a really good starting place. I also have a membership called The Hormone Project, thehormoneproject.com. It's a monthly membership where you can stop at any time, but curated topics. This particular month, I'm going deeper on testosterone. We do a Facebook Live. I'm going to teach you how to learn more about the hormones. I can answer questions about dosing. The live allows me to answer specific questions from members, and it's a more curated way for me to do one-on-one time with people that really want to learn more about their health, women's health, hormones, endometriosis, fibroids, hormones, obviously, and anything else that you want to discuss. It's $47 a month. And like I said, you can stop at any time. You get 20% off in the supplement store, 33,000 different supplements. So even if you order somewhere else and you want to just get a discount, you can do so through the membership. Today, I want to talk about something that is pretty controversial, and I kind of liken it to the cardiology battle against statins, and that is mammography, thermography, and ultrasound. These are 3 different ways to test breast tissue, as is obviously MRI. MRI being kind of the mother lode of tests and probably the most expensive test that you could do. So for years, women have gotten mammographies. And as far as I can remember, I mean, I've been practicing now since 1998. Oh my God, that's a long time. And the mammogram recommendations have changed a little bit. It used to be that once you hit 40, you should get a mammogram every 2 years and then a screening mammogram. And then when you hit 50, you would switch to every other year. I'm sorry, it's every other year, 40 to 50, and then every year after 50. And that would be also based on your family history, your personal history. Obviously, if you had a significant family history and you had women in your family that were breast cancer diagnostics that were, say, 38, then you would start mammograms a little sooner. And then about 2 years ago, they basically changed the overall specifications if you have no increased risk factors to every other year from the age of 40 on. And then there's different societies like the American College of OBGYNs, the American Radiological Association, National Cancer Society, and they all kind of recommend different things. So what is a mammogram? Well, a mammogram is a test that I have never had to have done. It's a very frequent question that I get, especially from women that are younger, that are coming up on that 40 age group when they have to start getting mammograms. And I get asked this question all the time. What's the difference between mammograms, ultrasounds, and thermograms? And I'll be perfectly honest. I used to think that thermography was garbage. And it's, we all have a learning curve. We all have things that we believe in and belief structures. And medicine, in my opinion, is kind of like a religion. I mean, we abide by the tenets that were proposed to us years and years ago, and sometimes things changed based on norms, based on standard of care, based on research. And I heard somebody talking once, and I looked back at the history of medicine just because I was bored. And if you look back far enough, there was a doctor named Ignaz Semmelweis. And he was practicing back in the 1800s, I believe. He was an OBGYN, and at that time, many women were dying in the postpartum period after they delivered their babies from puerperal sepsis or postpartum infection. They didn't really have antibiotics back then, and women were just dying. And they made an observation that the women that were dying were the ones that the doctors delivered, and the midwives didn't have death rates. Like the midwives had survivals, the doctors had deaths. And I'm sure there's people out there going, well, of course, the doctors had higher death rates. But what they discovered was, and Semmelweis is the one that figured this out, doctors would be up in labor and delivery doing deliveries, and then a woman would die in the postpartum wing, and they would have to go downstairs and do the postmortem or the autopsy. And this was back in the day when they didn't wash their hands, and to have blood on your schmuck, as they wore, was kind of a badge of honor. And so what they found, what he discovered, was that doctors were going from these postmortems on these sick women, then they were going upstairs, they weren't changing or doing anything, and they were putting their hands in the vagina and they were delivering a baby. And he said, hey, the nurse midwives aren't doing that. They're clean. They're not going down and doing these postmortems. Why don't we wash our hands? And now it's like, duh, of course we wash our hands. He was laughed out of medical society. He was a pariah. He lost his medical license, and he basically died penniless and in a psych ward because they made him go crazy because of the way they brutalized him in the medical community. And I would say, honestly, things have probably not changed a whole lot for people that have new ideas. So when I started looking at that, I'm like, look, dumbass, talking to myself, if that was such a crazy idea back then, why is thermography so crazy? And I started looking at it. And then I started looking at mammograms, started looking at the research and ultrasounds. And there's a lot of confusion out there on this subject, thinking that one might replace the other. And I have a lot of patients that do thermography instead of mammogram, or they want an ultrasound. I was just talking to a rep today for a company that's a major manufacturer of mammography. And I told her that about 30% of my patients, this is just a guess, don't get mammograms. They just flat out don't do them. And she said that in their company, they were having this very similar discussion. And I think they're kind of nervous because they think it's going to go higher, like above 50%. And so it got me thinking. And what's happening at the same time, I'll be totally transparent, as I always try to be. I am going through thermography training in my own office because I wanted to go deeper. And I'm always looking to add services to my repertoire that I see as being popular therapies. And I have tons of women that are going to get thermograms, and they're going somewhere where the person that owns the thermography clinic has absolutely no medical background, and they just get this test and then they don't get any follow-up. And I thought, well, at least at my office, if they have some interesting spot or some interesting finding, I can do an exam right there. I can order an ultrasound. I can order a diagnostic mammogram or whatever. I can do the follow-up. So I was like, Shawn, you got to learn more about this stuff. So both mammography and ultrasound are structural anatomical tests. They look at the tissues, they look at the densities, they look at opacities and calcifications. And so it's a structural test, it's an anatomical test, whereas thermograms are physiological. So it looks more at heat signatures and temperatures and in possible infections. And the thought process is being that infections and cancers have more of a heat signature because they have more of a blood flow. And so none of these tests are truly diagnostic technologies in the sense that they all have their false positives and their false negatives. Thermography involves the breast and the surrounding tissues and provides more of a, what I would say, a risk assessment, while mammography and ultrasound detect structural abnormalities. And then if a breast abnormality is found that they think might be malignant, they'll do a biopsy. And the biopsy itself then removes the tissue and they look at it under a microscope. So many women, after their initial assessment with thermography, may be asked to follow up with an ultrasound or a mammogram. But that's if they're going to a clinic where there's an actual physician. The problem is if you go to a thermography clinic where it's just run by, somebody that thought it would be a cool idea to be a thermographer, and they get a lot of training, but they can't really tell you what to do because they can't, first of all, give medical advice, and they can't order anything. So they have to send you to your doctor, and then your doctor's going to be like, oh, why did you do that test, and make you feel horrible and gaslight you. So, and thermography obviously is not covered by insurance, whereas mammograms usually are. There are basically some women will feel safer if they get a mammogram or an ultrasound, and especially if it's negative. But there's also high risks. There's people with family histories and things like that. So let's talk about the three tests: mammography, ultrasound, and thermography. And let's kind of compare the pros and the cons. And let's start with mammography. I already told you the screening for mammography. Sorry, I had to wet my whistle. It's a structural test. As I mentioned, it's an anatomical test. It looks for suspicious areas, densities, calcifications, spiculations, things that, have like octopus arms. It's a compression test of the breast. And I had somebody ask me today on Instagram if that smooshing part of the breast causes cancer. And I don't think so. I've never seen anything that shows that the compression from the breast tissue causes cancer. Now, the theoretical question would be like, well, what if you already have a cancer cell or a mass and you smush it? Are you kind of pushing it into the lymphatics? Are you pushing it into the bloodstream? I think there have been some studies that have shown that's definitely a possibility because of the trauma that it can cause spread. We know also that biopsies can do that as well because you're messing with the integrity of the tumor itself. So that's something to think about. It's X-ray radiation, and it produces an image. The area of concern tends to have greater density on the scan and stands out against the regular tissues. In medicine, mammographies are the number one reasons for lawsuits actually in medical practice, and that's because they don't want to miss. So because of that, they don't want to miss things, right? So what they tend to do in a lot of mammograms is overcall the test, meaning they will use lingo that says could be this, might be that, when then that causes us to have to follow up more. And one of the complaints is that are the radiologists reading these doing that because then they get to order an ultrasound, which then gets them more money. I mean, it's an interesting argument. It's the same logic of people who say that doctors only do C-sections because they get more money. And the reality is a C-section pays about $100 more than a vaginal delivery. Insurance has a way of making sure that that doesn't happen. But it's something to consider. It can detect tumors. Mammography can detect tumors in slow-growing stages or pre-invasive stages. It can't detect fast-growing tumors in the pre-invasive stage. So it has to be a slow-growing tumor because usually the fast-growing tumors grow so fast, by the time you have a mammography every 1 to 2 years, it'll probably miss it. In the case of hormones, there is some complaint that hormonal therapy decreases the sensitivity of the test. And my response to that is, then we need to figure out better testing because women need hormones, and to say that they shouldn't go on hormones simply because it's going to mess up or possibly decrease the sensitivity. And sensitivity in medical terms means that you get a true positive, meaning the way you calculate a sensitivity is you take true positives and you factor that over true positive plus the false negatives. And then that gives you a percentage. That's the sensitivity. So what they're saying is the mammography or hormonal therapy might increase the false negatives and or potentially decrease the true positives. My guess is they're worried that hormonal therapy might increase your false negatives because they have more dense breast tissue. Large, dense, fibrocystic breasts are also harder to read. Many women out there who have dense breasts have been told, don't bother getting a mammogram, just get an ultrasound. However, we tell women all the time to do yearly or monthly breast exams at home, and the detection on a mammography is about 1 to 2 years earlier than a physical exam. So it can detect breast cancers 1 to 2 years prior to an actual physical exam. The upper portions of the breast, including the tail, which is the part that points towards your axilla or armpit, is harder to visualize on a mammogram. The average false positive rate, we talked about true positives, but the false positive rate can be about 25%. And then 9 out of 10 biopsies that are initiated by mammography are negative. So the complaint is that that's a large number. I mean, if you have 1 million women getting a mammogram, and there's probably more, obviously, every year, there's probably 30 million or more, and you have 30 million women getting a mammogram, then 600, 800,000 of those women are going to have a false positive, and they're going to all have biopsies. Well, that's a huge number. And then 90% of those are negative. So here's the debate. Do we keep doing screening mammograms to help the 25 to 50,000 women that have breast cancer? Or do we not do it and not radiate the other 650,000 women who don't need it? And that's a huge debate, because it puts a huge burden on the medical system cost-wise. Mammography is a multi-billion-dollar business with the machines and the companies and the readings and the radiologists. I mean, it's a huge business. So to make changes in that huge business is going to take a massive paradigm shift. And then lastly, we talked about sensitivity, which is the true positive. The average sensitivity is only 80%. So 20% of cancers are missed in women over the age of 50. But it's what we have. So what are you going to do? So those are the issues with mammogram. It's not super sensitive. It's not super specific. If something comes up, they usually will refer to an ultrasound. So the question is, then I get this all the time, why don't you just order me an ultrasound? Because insurance won't pay for it. And I can order it. And I tell women all the time, I will order you an ultrasound. But I can't tell you if the insurance is going to pay for it, because they have a system. You have to have the mammogram. And then the mammogram has to be abnormal, and the radiologist has to say, recommend ultrasound. Then the insurance will probably pay for it. Now, there's companies out there like HerScan, and I'm not trying to throw shade at HerScan, but this is another one of those money grabs, in my opinion. It's a company that just does breast ultrasounds, and you don't need an order. You just go get your breast ultrasound. I got a report this week from a patient where the mammogram said that there might be something irregular. We would recommend you see your doctor. And that pisses me off, because I didn't order the test. And I don't get paid for ordering a test, but at least then I'm responsible for the results. So they skim all the money off the top, but then they don't want to have anything to do with the patient if there's a negative. They just want they are a positive. They just want the negatives. And that is a shitty business model, in my opinion. That is taking women's money, because here's what's going to happen. This is exactly what happened to this lady. The radiology groups that I refer to, Austin Radiological Association, they're not going to use the HerScan. They're not going to trust it. So what's going to happen is I got to order another ultrasound. So she's got to have another ultrasound. Then what happens if that ultrasound's negative, but that one said it was positive? Then I'm stuck, and the patient's stuck, because I don't know what to do. It just is a mess. So I wouldn't use HerScan, because I just think it's ridiculous. And why spend the money on something that normally your insurance would probably pay for if you needed it? So then we move on to ultrasound. Ultrasound, as mammogram, is a structural test. It's a test of the anatomy of the breast. It can pinpoint the location of suspicious areas. It uses sound waves with minimal contact on the breast. There isn't a lot of smushing. It's pretty painless for the most part. And there's absolutely no radiation. It's a high-frequency sound wave that's bounced off the breast tissue, and it's collected as an echo that produces the image. it's able to detect some tumors that are actually missed by mammography. But there isn't really any data on pre-invasive tumors. So those tumors where they haven't quite invaded yet. It can also be affected by hormonal management due to the menstrual cycle because the breast structures change with hormones and throughout your cycle. What it does that the mammogram doesn't do, it is allows you to look at that axillary tail, that little part that goes up towards the armpit, and you can look actually in the armpit itself, and you can look at the lymph nodes. It's good for distinguishing between solid and fluid. So that's the other thing mammography may not do, is it might just say there's a structural abnormality, send you to go get the ultrasound, and it's fluid filled, which means it's just a simple cyst that we either can drain or we can just leave it and watch it. The average sensitivity, so if you remember, the true positives on a mammogram were 80%. On ultrasound, it's 83%. So on an ultrasound, or on a mammogram, they're missing 20% of cancers. On a ultrasound, they're missing 17. So it's fairly similar. The average specificity, or your false positives, if you remember, on mammogram were 75%. So there's a 25% false positive rate. There's a 34% false positive rate with ultrasound. So it's a little worse than mammogram. So the two of them separately aren't great, in my opinion. We should have better. I agree. The two of them together are good. So that's why we usually go to the mammogram first, and then we go to the ultrasound, because those two tests together are better than each of them separately. So then what do we say about thermography? Thermography is not a structural test. It's a functional test. It's able to detect physiologic changes, but it can't pinpoint the exact location of a suspicious area. So a thermogram, while it's going to give you a heat signature, and there may be a heat signature in the upper outer quadrant of the left breast, it can't really specify exactly where it is like an ultrasound could, because the ultrasound and mammogram are looking at the exact anatomical tissues. The mammogram, or the thermogram, is looking at skin temperature changes. So let's say, aside from the breast, let's say we were looking at the heart or the area over the chest. And in thermography, blue, purple is cold, red, white is hot. And let's say you had a blue area over the heart. That could mean that that area is a little colder, which could signify that there isn't as much blood flow in that area, not necessarily the heart, but possibly the heart. And so that might be a reason to get something checked out, because it might show decreased perfusion in that area. So as you can see, it's not detecting an exact location. It's just giving you a physiologic array of that particular area. So it's not as specific. There's no radiation. Obviously, it's a camera. It's a thermal picture. It's non-invasive. There's absolutely no risk to the test. And it can be used as often as you want to observe the effectiveness. So some women will go every 3 months because they want to see how things have changed if they're trying medications or supplements or whatever. It uses infrared detectors that detect heat and increased vascularity that I talked about. And it can detect physiological changes many years prior to any other method of screening. It has a very high sensitivity to fast-growing aggressive tumors. So when you look at it, because those fast growers, they need a lot of blood, that shows up as a temperature change on the thermogram. Hormonal activity in the breast will also affect the thermographic image, but not to the point of an abnormality. So it might make things look a little warmer, because when you give estrogen and progesterone, it stimulates the breast tissue. It might increase blood flow, so they might have a total change in the color, but it's not going to be a specific pinpointed area as it would be if there was an actual abnormality. The specificity, or the false positives. So let's go over this again. False positives for mammogram, 25%. 25% of women getting a mammogram have a positive that's not real. Ultrasound, 34% of women that have an ultrasound have a false positive. Thermography, 10% false positive. So the numbers for thermography are a lot lower. So you don't have false positives, which is a good thing. The sensitivity or the cancers missed in mammogram, it misses 20% of the cancers. Ultrasound misses 17% of cancers. And again, thermography is only 10%. So most of these are slow growing tumors with a low metabolic rate, the ones that are missed. So that's its limitation. So of course, you've all heard by now that early detection prolongs life expectancy. And that's a given. We know this. The earlier you catch it, if it's a stage 1, it's usually just cured by excising it. Stage 4, if it's metastasized, not as good of a rate of survival. However, if cancer has been detected early, that means that you already have cancer, right? So I had this discussion with a lady the other day. She said, my mom started hormones, and 6 months later, she was diagnosed with breast cancer. That breast cancer was there before she started the hormone. Breast cancers, before they are detectable, are usually present for about 2 to 3 years before they can even be detected, either palpated by your hands or seen on a mammogram. So that breast cancer was already there. And so we should be trying to find things earlier than that. And prevention is obviously the precedent over detection. Prevention means just not even getting the cancer in the first place, so we can change behaviors. And so what I have decided to do is to learn about all these technologies to try and bring a good cancer detection system to my practice. And so the other problem with thermography is that it's not covered by insurance at all. And so for women that want a thermography, it's about $300 to $350. You can do whole body thermography. I just did a lady today who her sinuses were just lit up and she's got allergies. Her thyroid was also lighting up on the left lobe. So we're going to run some thyroid tests. And it just gives you that ability to be a little bit more like Sherlock Holmes and try to find things earlier. Now, I know there will be doctors out there that will scoff at that, oh, you're just using it to order more stuff. Again, I don't make any money ordering labs. And I might find that she has early Hashimoto's or something. I think that's a great way to look more at prevention or at least early detection. And why not use it if we have it? Now, there is a new test coming out called the QT scan. It's starting. It's not full blown yet. I don't think it's covered by insurance, but I do believe it's FDA approved. QT imaging is a system that basically provides a highly accurate, 100% safe, painless breast imaging. And it actually helps with screening because currently, as I was talking about, only about 65% of women follow current guidelines. These are women aged 40 to 70. And 35% of women don't follow up because they don't want to get another one. So it's basically the QT scan is a breast acoustic system that's non-invasive. It was FDA cleared, and it's ultrasound together with reflection. So it's a complementary system, and more women have in studies been seen to follow up with it. Now, it's not FDA approved, it's FDA recognized, and they understand that it's an important thing. Now, the reason that I bring this scan up is because it's going to start coming out, and I think it's great. I think the more you can do, the better, and it's non-invasive, doesn't have any radiation. But I'm going to be surprised if it replaces mammography because, as I said, mammography is a multi-billion-dollar business, and it's going to take a mountain to move, or it's going to take moving a mountain to do that. So it will start working its way in. I think it's going to have more legs than thermography will. Unfortunately, it's way more expensive. It's for a doctor to have a QT scan is probably $150,000 or more versus a thermography machine, which is probably 17 to 25,000. So anyways, I'm going to start offering thermography in my Austin office because I think it's just a part of what you want to do. And you can do breast, you can do torso, head, body, the whole 9 yards. And I just think the more that you can do for early detection, the better. I talk about this with heart disease and the CT calcium score of the blood vessels, carotid intermedial thickness, or in the carotid artery, measurements to see if you might have pre-existing heart disease, specific cholesterol panels. This is a way to potentially screen for cancer. And, there's another test out there for cancer called Gallery. Not yet a fan of it because we all have cancer cells in our body at any given time, but our immune system gets rid of those on a daily basis as well. So you might take the Gallery test that says you might have some cancer cells in your body. Also has false positives, which could scare the living bejesus out of you, right? If you had a positive test, but it doesn't necessarily confirm that you have cancer. It just says you have a cancer cell. Now your immune system may totally destroy it. And then if it's so early in the process that they can't detect it, like let's say you had a breast cancer cell in your body and we can't find it, what are you going to do? You're going to go get a mastectomy? I mean, it's just tough. It's a tough test to swallow. And I feel like it's, Russian roulette for patients. So thermography, mammography, ultrasound, they're all part of your health and potential prevention and diagnosis. I would encourage you to use whatever one you think is resonating with you. As a physician, I have to order mammograms for my patients because it's the standard of care. I'm not going to drive you to the appointment, but I'm going to order it. And I'm not going to make you feel guilty because you're an adult and you can decide what you want to do. But I think I just wanted to let everybody know that these tests are out there. They're amazing, they're helpful, and you should use whatever sounds right for you. I hope that was informative for you. Remember thehormoneproject.com if you want to go more in depth like this, because this is exactly what I do in there. And I answer specific questions, and we have topic driven deep discussions where I have videos that I've uploaded. So there's more information there than you could ever want. You get a discount if you become a patient. You get a discount in the supplement store, which in and of itself might pay for the membership every month. So keep it in mind, hormoneproject.com. The Hormone Balance Bible is available on Amazon if you want to go even deeper on hormones. It's 500 pages of the 12 most common hormone imbalances in women. I hope you have a great weekend. Take care.